think in the interest of everyone's time, it would be good to get started. So I have very little voice. I hope people can hear me. But I don't think Dr. Stack needs a long introduction. So we want to welcome Dr. Stack, our Commissioner of Public Health today, to talk to us about monkeypox. And I believe Dr. Stack has some guests that he'll introduce.
I do. Thank you. And thanks, Deb, and thanks to the Hospital Association for making this possible. So I'm going to provide some framing remarks, and then I'll tell you who I'm going to turn to from our team here. My hope is to take the first 30 minutes to kind of share information, share resources, leave behind a slide deck for you, and then spend the balance, the second half hour, as long or as little as the group needs to answer questions. I just want to contextualize this. We got through COVID better because do I have an echo on my end? Okay. We got through this better together, I think, in COVID, at least from the sense that we held together as a community because we collaborated and communicated often and regularly. Monkeypox may well be a variation of that, though obviously not with the same disruptive impact that COVID had on your facilities and your staff. So here's my high-level comments on this. Monkeypox has spread far more widely than ever before. I think most of your clinicians on this call know that. It typically had been in West Africa and Central Africa, and when it left there, it left briefly and in small manners. This is clearly not that. It's spread throughout the world, and it is rapidly escalating. It typically hits the men who have sex with men community, so gay and bisexual males, and even a subpopulation within that initially, particularly forcefully, it has impacted that community. The amount of vaccine available has been insufficient. The amount of treatment available has been limited. There's really only one usable vaccine for this purpose, which is Jynneos, and our team will talk about that in a minute. The other vaccine has significant downsides to it, so we won't dwell on that unless there's questions, but most states, actually nearly every state's not even using it for this purpose. The TPOXX, the treatment, has other challenges that go with it as far as availability and the paperwork that goes with it, and we'll cover that. One of the reasons I wanted to reach out to this community specifically is because in a time where there'll be a lot of uncertainty and insufficient access to the vaccinations and the treatments that people rightfully want to have to give to people and have by receiving it for themselves or people they care about, we're going to have to really keep communicating with each other to make sure we're on the same page so we don't start getting in each other's way and causing problems that we could otherwise avoid. Additionally, remember, I'm an emergency physician, folks. I spent 25 years plus, training to be an emergency physician and then working and running ERs. There are going to be plenty of people who show up with rashes places and say, I think I have monkeypox, and other treatment locations are going to say, go to the ER, right? And so that is the default in the United States of America when someone shows up somewhere and they either don't have what they need to take care of them, or for whatever reason, they're unable or unwilling to provide that care. They say, go to the ER, and then that means it becomes an emergency department and a hospital-based issue. I am confident, I'm going to say this only in the positive and the affirmative, I am confident that, that in Kentucky, we are going to rise to the challenge and take compassionate care of all these individuals, whoever they may be, who show up in the hospitals and the emergency departments for their evaluation and treatment. We don't want to encourage people to go to the emergency department for this. We want to encourage them to go to, if at all possible, their primary care clinic, their Ryan White clinic, their STI clinic. We want to try to use those other locations for this. But when it happens otherwise, I'm confident that when they show up in the emergency department, my colleagues and the staff are going to take good care of them and do the best they can. I also want you to hear from me as we navigate this vaccine supply. It's important to me that we make sure we have vaccine available so that if healthcare workers have exposures, we can provide post-exposure prophylaxis to healthcare workers, regardless of their clinical role, so that no healthcare worker feels that they are accepting a risk without the benefit of some kind of protection. We are not currently at any kind of pre-exposure prophylaxis. That is just not where the response is due to supply limitations. But if clinicians become exposed to the virus, we want to make sure you have pathways to try to access, and we can hopefully timely provide access to vaccine for healthcare workers and clinicians who may get exposed, and even if they're non-clinicians, laboratory workers and others who may get exposed to the virus. We want to make sure that they're protected. So what we're going to do is Dr. Bethany Hodge is our infectious disease branch manager, and she's been one of our principal leaders for this response. And then Dr. Kathleen Winter, you've met before, is our state epidemiologist. Bethany's going to go over a quick overview of the virus, where it is, and leave some things unsaid in the slide deck where you have more information. Some of you have probably seen CDC decks, which are even longer and are actually very well done for the most part. Dr. Winter is going to go into some more specifics about the vaccine, and we have other members of our team here to address any comments or questions that may arise. And I'm going to put a bow on it as we transition into Q&A and then and move on into the Q&A. So Dr. Hodge, if you want to take it from there, I'd be grateful.
All right, I believe Dr. Winter is going to be sharing the slides. There you go. And as he said, there's going to be more things on the slides than I'm going to say, but you will be able to receive the slides if you want it. Also, just so you know, my background is as a pediatric hospitalist. So how to protect a hospital, how to keep patients safe and staff members safe at the same time is something that's always in my mind too. Next slide. So we are in the place right now where we had sort of the traditional knowledge of this virus and the textbook pictures that look like the top right one. And we thought that we knew how this disease presented and what to expect from it. So things that we say traditionally, there was preceded by a prodrome, and then these many lesions pop up all over the body, and that's how the illness looks. We also do know that the infectious period starts from the beginning of the prodrome and lasts until the last lesion scab fall off and there's new skin formed. So this illness is really one that can be protracted in that the beginning to infectiousness and then to the state where the new skin is formed can be quite long and is different from other disease processes. Next slide. However, in this outbreak in the United States right now, we are seeing a little bit different morphology and presentation with fewer lesions, smaller lesions, sometimes only lesions on the mucosa or in the genital regions, and not quite the same pictures as those old textbooks have had. Next slide. And I got this data from the CDC website yesterday. And so you can see thousands and thousands of cases across the world. And as Dr. Stack said, this is known to, there's the West African clade, which is what we believe we're dealing with right now. There is a different variant that comes from Congo area that is more severe, but we do not see in our samples that we have in the United States right now. But as you can see, there is some activity in those countries where it's endemic, but there's so much more activity in countries that have never had this before. And that's part of what is causing the need to respond in a different way than we ever have before. Next slide. And this slide is already out of date. So we do now have 10 confirmed cases in Kentucky, and the CDC just switched from just a map that said whether or not you had cases in your state to this sort of density map. And you can see that Kentucky is on the map. We have cases, but there are certainly states that have a lot more cases than we do. So we need to figure out our response, but we are not in the same position as some of the other states, even states close by us, that have a lot more cases and a lot more to deal with. Next slide. And just to look to, this is the speed at which this outbreak has started and really ramped up. And this only goes to 7/28 with the last date on that graph there and a little bit beyond. So we're still in a phase where we're having some exponential growth of cases and transmission here in the United States. Next slide. I won't read all the words on this page, but this is the case definition that is happening. And we are featuring the rash that has to be this characteristic rash, although, as I said, is not always presenting as dramatically as clinically typical. And then it has an epidemiologic criteria that we'll get to talking about. This really has been the same story over and over again with the positives that we've had here in Kentucky and that have been consistent throughout the United States. The CDC website also lists several different ways to test for monkeypox, but we are really only doing the PCR testing that was highlighted there. The other forms are not being done routinely by anyone that I know of. Okay, next slide. These epidemiologic criteria. So reports contact with a person or people with similar appearing rash, or close or intimate in-person contact within these social networks, which right now have been defined by being in the MSM community or with, especially with partners that were new or anonymous. And there seems to be a lot of state-to-state travel in the cases that we have come to know, and this repeat story of an MSM individual who does have partners that they meet and have sexual encounters with, but that they don't know very well. Next slide. So what we've been suggesting throughout this time as we try to gather information, develop the patterns, make sure that we're not seeing things that are outside the patterns that we're expecting, we've developed these kind of processes. We did start out with acquiring digital photos of the lesions, and initially that was at the CDC request to try to build their database of how this outbreak was appearing on different colors of skin and different instances, things like that. They are not as into that right now. I think with over 7,000 cases, they've maybe got enough photos for what they need right now. But if it's needed for the patient's own personal medical record, I think it still can be useful, or for discussions with specialists or other people if you need to discuss the case outside of your facility. This method of testing is a little bit counterintuitive for a lot of people. You may have a lesion that is sitting there and does appear to have fluid inside, but unlike a bacterial swab that we're going to take, we don't actually need the fluid from inside the lesion. You're going to be swabbing or brushing around the lesion. The type of swab used, that dry Dacron or polyester swab, is important. And then putting it in a sterile container, it doesn't have to be anything fancy. It can be a conical tube or a urine specimen cup, and then refrigerate or freeze for shipment. For our process here at DLS, we are not requiring or even wanting transport media because there are various types of transport media and confusion that can happen with those different things. We are not using a process that uses any media at all. We do want you to call, however, and discuss the case either during the daytime with us or with that report line so that we can prepare the lab for receiving this specimen. We know where it's coming from. We know the timeline to expect that it's coming. And then we're using the EPID 200 form, which is usually used for positive findings that you need to let us know about for reportable diseases. We're using this at the time of gathering the specimens so that we can inform the local health department, be prepared for the sample, and know about the response that we may need to form. We're also informing all callers and people that are wanting more information on how to test for monkeypox and reminding them to call their facility infection control. We found that they've been really useful partners, not only for making sure everybody else in the facility is safe and handling waste and things like that, but so that there's another person in the system in the loop on what's happening with the testing and positivity from that facility. Next slide. There is expanded lab capacity for this testing at this time. So if you have a lab, a commercial lab that you are completely familiar with and feel comfortable with, I know some of the big ones have come online, Quest and Aegis and others, they are doing commercial testing for orthopox virus, and they all use the same sort of swab for PCR. Quest does require viral transport media, so that's something to know. Otherwise, we're not always keeping up with the choices that the other commercial labs are making. So it would be important for you to know what your commercial lab's requirements for the tests are and disseminate that throughout your facility to make sure that you're doing the current practice for your commercial lab. We will note that turnaround time is sometimes various. Sometimes we can get things done quicker at the state lab, and we don't always know the turnaround time for the other labs. That may be something that your lab personnel may better know than us. Next slide. Just to go over some of the terms used and when we start doing things. So a suspect case is when a clinician has concern for monkeypox. A probable case is when a swab is done and is positive for orthopox virus. And that's at that time that we can act. We can start doing the things that we do in public health and for the patient to treat it as a presumptive case of monkeypox. And that's because there are no other circulating orthopox viruses in the United States right now. So if it is orthopox positive, it's pretty much certain that it's going to be monkeypox. We do send a confirmatory swab off to CDC for that confirmatory testing and other genetic analyses of the sample to make sure that we're dealing with the same thing that we thought we were. And then it's called a confirmed case. But that's where the terminology comes from and why we act when there is a probable case. Next slide. So steps that can be taken with probable cases, there's the public health response and then the patient response. For the public health response, we do involve the local health department. We do contact tracing. We do offer post-exposure prophylaxis vaccine if anyone is determined to have a high risk exposure to that patient. And then we do all the reporting to the CDC. For the care of the probable case, we have isolation guidance that comes from the CDC, and then we'll do other things that may be pertinent to that person's particular manifestation in case of monkeypox. This TPOXX we'll talk about a little bit more in a different slide. The main clinical symptoms that have required management during this outbreak have been pain, because there is a larger proportion of patients presenting with mucosal lesions, so oral, rectal, and urethral. They may have extreme pain and difficulty with normal everyday functions, and that's been the cause of the few hospitalizations that we've had in the United States. Thankfully, because this is the West African clade that's less severe, we're not seeing, and I have not seen reports of things like pneumonia, encephalitis, or other sorts of severe manifestations that have caused hospitalization. It's mostly been for pain. But we will keep watching for any other manifestations that are leading to severe outcomes as well. It's also important to note we have not had any deaths reported from monkeypox in the United States. There are some worldwide, but I have not read of any that have occurred in the United States. So it's a very painful disease, and it needs care and it needs management as far as the protection and public health measures, but clinical outcomes have been pretty good. Next slide. This is just a look from a CDC slide about the median age. It is, in all of our cases, have mostly fit this as well, where it is a male who is in the 30s to 40 range, and the heavy predominance of men who have sex with men. Next slide. So this has caused some controversy in different circles to whether or not we should consider monkeypox an STI. We do think that sexual encounters are the highest risk type of encounter at this time for this outbreak. And the mucosal lesions are hinting at possible transmission through bodily fluids. And we are seeing that, at least in the initial report that I saw, about 30% had co-infection with another STI. So it's definitely something that needs to be taken into consideration. And I think for you all, knowing that people who are working with these patients with suspect cases or with cases of monkeypox need to be comfortable taking sexual health histories. It took some additional training on our part to get our public health investigators comfortable with all the questions and the things that need to be asked. And so we're trying to balance useful targeting of the populations that are most effective in supporting them adequately versus harmful stigma where we are acting in a biased way that is causing negative outcomes. Next slide. Under the categories of vaccines and current medications, these are all part of medical countermeasures. These are all coming down from the federal stockpile, the strategic national stockpile that would be used in response to a smallpox bioterrorism attack, which is why we're not finding these in every pharmacy and Walgreens and CVS across the US. These are coming from a specific stockpile. In the vaccine category, an older vaccine that was available, the one that leaves a scar on your arm, is the ACAM 2000. It's a live vaccine. It has sort of a wonky delivery system, and it has high rates of side effects. So we're not using that in Kentucky at this time. The other one, the Jynneos, the live attenuated, we have, as Dr. Stack said, we have some strategy to our placement so that we will always have some available for healthcare workers and other sorts of public health responses that we need to make. And then we are now using the PEP and the PEP++ strategies, which I'll go over on a different slide, to vaccinate more citizens. And just so you know, it's 2 doses, 4 weeks apart, and you achieve maximum effect 2 weeks after the second dose. So it's really 6 weeks from start to finish before you can feel like you've reached your maximum effectiveness of that preventive vaccine. The medications that are in use, the main one that we are going to talk about, and main one that is being used, is this TPOXX, Tigaviramat, which is an oral medication, which is a 14-day course. It does have investigational drug paperwork that goes with it. So it is not the easiest to prescribe, and something that we need to work with the federal government to get our supplies, and then work with the providers to be able to have them effectively prescribe that. These other medications are IV and inpatient only. We have not used them so far in the state of Kentucky. Next slide. I guess that's it. And I'll turn it over to Dr. Winter.
All right. Thank you, Dr. Hodge. All right, I'm going to focus a little bit more on the vaccine side and where we're at with our current strategies and expand on what Dr. Hodge just said. But I did want to talk a little bit more about our exposure assessment and PPE guidance. So there haven't been any documented cases of transmission to healthcare personnel as part of this outbreak, at least as of the last several weeks. So that is not thought to be a major concern, though it still is a theoretical concern. We do know that transmission likely requires close ongoing contact with a symptomatic individual. However, risk is there, and healthcare personnel are recommended to wear full PPE, including an N95 respirator, gown, gloves, and eye protection when performing an exam on a patient with monkeypox or suspected monkeypox virus, or doing any sort of aerosol generating procedures, or when you're present in the room during those procedures. So CDC has updated their guidance. They're continuing to update their guidance on this. And if there is such an exposure where there's not full PPE being worn, we will work, the health department, your local health department should work with you to help figure out how to get the vaccine that you need for any sort of post-exposure prophylaxis, or where to send your healthcare workers who may have had some sort of exposure. I did want to mention that though we haven't had infection to healthcare workers through occupational sources, we have had healthcare workers who were infected through other means and who worked while infectious. So that is certainly a potential risk, and those potential exposures to your patients and your other healthcare workers do need to be assessed as well. In terms of management of close contacts, I just want to highlight that there is no quarantine recommendation. So someone who has been exposed, who does not have symptoms, they can continue to work, they can continue to be out in the world. They are recommended to get vaccine if it's a higher intermediate risk exposure, but there's not a need to restrict any sort of movement or have any sort of work considerations. All right, so as was mentioned, the Jynneos vaccine is what is currently available here in the US and in Kentucky. One thing I just want to point out on this slide is that this vaccine is licensed for use for both smallpox and monkeypox virus. So it is a licensed vaccine. And we have heard that there are some potential modifications that may be coming that may help extend the use of this vaccine. So we don't have any specifics on that quite yet, but we know that there's some considerations around either extending the second dose or potentially using a different delivery mechanism through the intradermal route and using some dose rationing. So it is possible we will see some additional guidance coming from CDC on this, and we are all anxiously awaiting that information if and when it comes out. So currently, the Jynneos vaccine in the US, so there's not a good supply globally, but supply is ramping up, and additional doses will be coming down the pike. Currently, the vaccine that is available, those allocations are being made to states based on the number of monkeypox cases that are currently in that jurisdiction. And there's an algorithm that assesses who they think the high-risk population is and what those numbers look like. So it's safe to say, based on our low case rates here in Kentucky, that we have had a very low amount of vaccine that's been allocated to Kentucky. And I know that this can create frustration as we see what is happening in other states with some larger mass vaccination clinics and just more widespread availability of vaccine, which we do not have yet here in Kentucky. So to date, we've received 3,500 doses of Jynneos vaccine in the state. This has been through several different phases, and that vaccine has been distributed to local health departments. We've focused on distribution through the urban centers, as well as to some health department regional hubs, so that vaccine could be mobilized and made available for post-exposure needs. So the health departments who have vaccine are working with their community clinics and partners to identify good locations for providing vaccine and or for referring individuals who are high risk to where they can get vaccine. So if you are a clinic, or if your facility has an outpatient clinic that provides a lot of services to this high-risk population, and I'll go over the the eligibility criteria, please reach out to your local health department if you think that you could be a potential source for providing a large amount of vaccine to this high-risk population. If we don't have the ability to get you vaccine now, knowing that there's interest, and we'll try to work towards that in the future. So just to review, so we know post-exposure management is when we have a known discrete exposure, and we are often using contact tracing to identify those individuals. Where we are now in this pandemic, this outbreak here in our strategy currently, both in the US and in Kentucky, is in a PEP++ or an expanded post-exposure prophylaxis recommendation. And this is really because there are so many individuals who are at risk in this outbreak who have had recent exposures, but they can't be discretely identified. And this is because of the nature of the exposures. We have a lot of people who have anonymous high-risk sexual behavior. And so we know that there is transmission occurring to individuals and we cannot identify them. So this is not a pre-exposure prophylaxis strategy currently, where we're just trying to target people who we think may be engaging in future high-risk behavior. We are truly looking for people who have recently engaged in high-risk behavior and who may have been exposed. So currently in Kentucky, who can get vaccinated includes anyone who's getting vaccinated as part of a PEP strategy. So someone with a higher intermediate risk exposure to someone with known monkeypox. And then anyone who falls into our PEP++ category. And we include these 3 different criteria here. This includes men who have sex with men, who have anonymous sex partners in the last 14 days, who have had a diagnosis of gonorrhea or early syphilis in the past 12 months, or who are on HIV pre-exposure prophylaxis. So again, this does not include all men who have sex with men. It's really men who have sex with men that have these other clear characteristics. We also have these 2 other categories that allow for administration of vaccine to individuals who have a reasonable suspicion of exposure, but maybe don't quite fall into one of these boxes. And this is really to be used at more of a case-by-case basis for people who report attending events or venues where there was known or suspected transmission occurring, and individuals who just for other reasons maybe are high risk for having been exposed. So we have a number of needs for communication. As I think everyone's aware, a lot has evolved in this outbreak quickly. CDC has quickly ramped up their website. There's a lot of new content every week that's being added, and we too have tried to ramp up our website. So there's a lot of public-facing content as well as information for healthcare providers. We have established a new monkeypox hotline here at the state. This is for the general public. So if you have people calling for questions and you just want to refer them somewhere, you can refer them to our state hotline. And this is our website, which we too are continuously updating and curating. And then finally, there's a number, like I said, on the CDC website, specifically for infection control guidance, and for waste management and different recommendations for healthcare and laboratory workers. And then finally, you probably are aware of the KHA calls, the CDC clinician update calls. There have been 2 specifically on monkeypox virus, and both were excellent. Both are recorded and the slides are available on the CDC website and have a lot more information about different lesions and different things to look for and doing a clinical assessment. So please do go to the KHA website and look at those slide decks if that's of interest to you. All right, I'm going to end the presentation and I'm going to turn it back over to Dr. Stack.
Great, thank you very much. And look at that, right at 3:29, so perfectly at that half hour, so pretty good. So Kathleen or Bethany, if someone can send the final version of that slide deck to Deb Campbell at KHA, then she'll distribute it to folks. Did you comment, Kathleen, did I hear you? Did you comment on the newest development with Jynneos vaccine?
Yes, just briefly, and this is, you're referring to the potential intradermal use and dose rationing. So just a brief mention on that, because we don't have any specifics, but we do think that this recommendation may be coming.
Okay, so this will continue to evolve. It will change from, rapidly in the weeks and the months ahead. I wish we had more vaccine. We do not. We are now trying to get it out as much as possible to as many high-risk persons as we're able to who meet the eligibility criteria. So that's post-exposure and then this PEP++. How they came up with that, I don't know. But anyway, the expanded. So your high-risk population in a high-risk setting, where there's known exposure has probably occurred for others. So we'll work through that, and we will do our very best to try to improve over time access. So you all know if you have an exposure in your facilities or for your teams, how you can reach out to us to get it. And all the information that Dr. Hodge and Dr. Winter gave, hopefully you can make use of that. I think what I'd like to do now, if we can, is we've addressed some of these questions here. But do other people have additional questions that we can answer or respond for you?
I can speak a little bit more about, there's a concern that the PEP is best given within 4 days of exposure, and that is true. It is considered definitely up until day 14 and possibly even otherwise with other considerations. So don't think that just because someone is beyond the 4-day window that they cannot get PEP. It's just that it's most effective at that time.
So Steve, this is Tom Miller at University Louisville. I'm hearing something a little different than what I first thought, which was all testing should be directed to the Department of Health in Kentucky. That's not what you want. You want us to go ahead and do testing at the individual doctor's office, but then send the results to the Department of Health?
So, well, I could comment, but Kathleen, do you want to take it or Bethany?
Sure, I can clarify. So testing can be done through any commercial lab that offers testing, and now there's at least 6 or 7. If it is a high risk situation where you really need results quickly and you want to engage with us and use the state health lab for testing, we can support you with that. We will need to approve that testing before it comes through. So that's when you'll need to make a phone call to that number that Dr. Hodge shared and have a consult with us just to be sure that we can get that specimen through to the lab. But if you have any patient can be tested that you think needs to be tested, and that can go to a commercial lab, no trouble. We do need the results reported. So this is now a nationally notifiable disease, and it's being added to our state reporting regulation. So the laboratory should be reporting those results. But in addition, if it is a positive case, then we need that EPID 200 completed. And if it's being tested through our state lab, we also need that notification with that form.
So Tom, I'll add to that from like a clinician's perspective. There are going to be all sorts of people who come in with rashes and say, I think I have monkeypox. And the clinician is going to say, you don't have monkeypox, but I'm not going to argue with you about getting a test. Send all that to a commercial lab, because you'll get an answer in a few days and you can say, yep, you don't have monkeypox. And if they do, then you'll still find it. But if you have someone who comes in who's in an MSM community and they've just gone to a rave, and someone at the rave had monkeypox, and you're like, no, I think this really is monkeypox. Well, I would encourage you to engage with public health, because you can start treatment based on presumptive, so if we can get you TPOX, you can start treating your patient. And then we could do the testing, but then you do have to give us the information we need for epidemiological investigation. So I would say the public health is there to support your clinicians for high risk, high likelihood situations where a rapid confirmation is you feel of high clinical utility, and or where you have a public health specific concern or interest. But for the multitude, all these people showing up with a rash, and you're like, any monkeypox, send all those to the commercial labs, please. We don't have the bandwidth to handle that at the state lab. Does that help?
Yes, and I agree that it's a bandwidth issue. I would say that we are purposefully not just testing people in the strict epidemiologic criteria, though, because we do want to have some eyeballs and some feelers on high sensitivity cases. Otherwise, a person who came in active labor who had lesions, we felt like we needed to test right away. Someone living in a congregate setting like a jail facility, that has such importance that we're going to use the state lab for that as well. So it's the high likelihood based on appearance of the rash or epidemiologic criteria, or of high importance for some other reason.
And that's the public health interest part that she just gave those good examples for.
Dr. Stack, can you see Dr. Bryant's question about the contraindications in the chat?
Sure. Who wants to handle that, Kathleen? And so it's what are the contraindications and precautions for Janaeus?
Yeah, Dr. Harrington is on, and I think she could handle that question.
and this specifically you ask about eggs, Cipro and gentamicin, that those are contraindications. In some literature, it talks about if you really feel like this patient needs this vaccine, to send them for allergy testing. What we're recommending is that you do not administer Jynneos. And at this point in time, we don't have a vaccine for those individuals.
Dr. Stack, can you see, or I don't know who wants to answer the question. Can you see the question about, I think we answered the question about reporting.
I can answer
Well,
the question about the universities coming back into session. We're
Perfect, thank you.
gearing up to potentially have another talk about that. This is definitely
Mm-hmm.
going to be an issue because of the congregate living settings of university students and also their personal habits. We're more than happy to provide more education. There is some guidance on the CDC website too, which I think took a little people by surprise when they have some extensive guidance on safer sex. It reads a little weird. And then there's also things like, please remember to clean your fetish gear, which seems really out of place until you start learning about the pathophysiology of this disease. And that's kind of where things are relevant. This can stay on some surfaces. And so there's some concern about that. I think overall, we're going to need more awareness and then to develop the mechanisms for testing to happen on campus settings. And then the same as COVID, we may need the ability for students to isolate in a different way than they typically can in a dorm, and we'll have to sort out those processes.
So we are in the process of scheduling a call probably with me and just one or two of my team with the presidents of the universities and the colleges and their health lead, just to socialize them to where the resources are and how we're doing this response. And then we'll follow up with them so that they're aware. Dr. Van Sickles put a comment in here, and I just ask any of the hospital folks if you want to share in the chat any responses, because you're more proximate to that. The question is if patients have encountered problems with bills from commercial labs for these monkeypox tests, and if anyone has any thoughts to offer. Dr. Van Sickles is at the infectious disease department at University of Kentucky. And then what about these other questions in here, Kathleen or Bethany? Dr. Fadi here has a comment about the case definition. Or Nina Reynolds might type that in there. So broadening the case definition to include genital lesions and atypical skin manifestations. I think the CDC ultimately determines this case definition at this point, but Kathleen?
Yeah, I would just add that we would certainly, in terms of clinical suspicion, that's certainly appropriate for who you may want to test. The case definition really relies on testing, so a probable case is from the CDC is all about having laboratory confirmation. So there is some recognition that there can be some atypical presentation.
I think the second part of the question also ties into the prioritization of TPOXX. So we do know that the Venn diagram with HIV positive patients is very significant with this current outbreak, and that is something that CDC has a specific page on considerations for monkeypox in HIV positive patients. They still are recommending Jynneos. They haven't recommended any different vaccine schedule or additional doses or anything as far as I know of. They do think that the vaccine can be efficacious. And then as far as TPOXX, there is a place where if you are immunocompromised, including HIV, that would be a consideration for giving TPOXX. But on some of the recent calls I've been on, they feel like if you are on your HIV medications and effectively not immunocompromised, that you do not necessarily have to be on TPOXX to do well and clinically with monkeypox. So as far as the prioritization, it seems to be severity of disease. It can prevent things like that, hospitalization for pain and things like that. Or if there are other considerations of how it would be detrimental to the patient to not have TPOXX, but it certainly is not being prescribed or given to everyone who is positive for TPOXX for monkeypox. I think our current state in Kentucky is less than half of our patients who have been positive have qualified or needed TPOXX at this time.
So I would say this is not, obviously it's not COVID for so many reasons, and there are a lot of differences, but I would say to the extent that it's within the parameters that the CDC, has encouraged or allowed us to use the medication. I would like to defer as much as possible to clinicians exercising good judgment. That's what we did during COVID. I think that's what we'd like to do now. But that also requires that clinicians don't just throw open the floodgate and give anybody, try to give anyone TPOXX they want. I'm confident the burden of paperwork associated with giving the drug will be a dissuasion to people being cavalier about the medication, but I hope it will not be a dissuasion to people giving individuals who need it access to it. And so the CDC did streamline the forms a bit. I suspect nowhere near as much as we would want, but I do hope we'll get it to the people who need it. There are comments in here. So as far as preferred agents for pain and all, that's kind of, I would probably defer that to a clinician called Bethany. I don't think so there's kind of a little division of labor here of sorts. So individuals like Dr. Van Sickles and others who are in clinical treatment settings are doing webinars and calls where they are sharing what they are seeing for clinical treatment of patients. I would say we generally are going to deal with the disease containment, access to the vaccine, when to use it, when not to, and access to the treatment, and perhaps to some extent when to use it and when not to. As far as some of those more specific clinical items, I would say that's kind of like COVID, where we really relied on the clinicians in the clinical setting who are actively treating to share with each other through various fora, what they're seeing and what they find beneficial. Amy?
I just wanted to share, there's lots of questions I'm sure you all are receiving about vaccine. And as we discussed earlier, vaccine has been placed in regional locations across the state. And many of those health departments have already begun reaching out to their local hospitals just to give you a heads up that they do have vaccine. So I would reach out to the health department in your city as well as your region to find out where vaccine is available, so you can refer patients to if you get phone calls, or if you have hospital-based clinics, so they know who they might be able to partner with to offer vaccines in those clinics. We have worked really hard to make sure that Kentuckians wouldn't have to drive far if they needed vaccines. So there are lots of regional places that you can refer your patients to.
Amy, can you see Tom Miller's comment there? Just for our team to consider how we package information. I think he's looking for a rip and read kind of one pager that makes it easy for people to put on the corkboard in the ER, behind the clinician's desk and things like that, where people can just look up and reference stuff. So
for vaccines or just general monkeypox information?
I think he wants general. I think, like, if you want to file a report, here's what you do. If you want to, ask a question, here's where you call. If you want to get vaccine, here's what you do. So I think it's just as much as we can to make just a one-page reference resource for, and for all the other stuff, go to this webpage and here's where it'll be. Right, Tom? Did I get that okay?
Yeah, you got that. Well, I'm just trying to get it out to 800 providers and try to get it in a way that makes good sense and easy for them. They won't go through this presentation, nor will they understand what you ask.
Yeah. No, I know that, and it'll change. As soon as we tell you this week, it'll change next week, and then everyone will be mad at us because we told you the wrong thing. Just to give you an example again, we were all on a call last week at 2:30 in the afternoon, where we were on a nationwide public health update call for this. At no point on that call was there any mention that at 3 o'clock that afternoon, the President of the United States would declare this a public health emergency. So we hung up that call, had no knowledge of this, and then we start getting our notifications on our phones that CNN and other people are reporting that the president made it a public health emergency. The change for the vaccine, the possibility of using it intradermally and using 1/5 of the volume to effectively quintuple the number of people who can have access to vaccination, that is something that they have now just run through an FDA process and have determined that I think they're going to be announcing it on a White House call that was at 3 o'clock today. So they probably already covered that while we were on this call. But there's a lot of people who don't do intradermal injections in a lot of these settings. And so there's other issues that we're going to have to navigate as we go through that, and then train and educate people. And there's all sorts of adjustments. And you may remember the 11th dose and the COVID vials. the COVID vaccine vials. Well, imagine when you have a bottle that's barcode labeled for 1 dose, and now you're going to split it into 5. So it's going to, I'm sure there are going to be all sorts of implications that make a real nightmare for inventory tracking and other things. And yet that's just where we are, and we'll do our best to work through it. And we will start reporting probably once a week publicly, because we have an obligation to be transparent, how much vaccine the state had, it was ordered, and how many doses have been given. And we'll break it down by a few high level things, like how many, maybe how many per county or something like that. But remember, this population is mobile and travels. This is not like a homebound population who never leaves their house or the nursing home. And so those statistics in some ways will be helpful, and in other ways may be misleading. We are not going to turn people away. So the goal will be to prioritize Kentucky folks and schedule through our clinics Kentucky residents. But if there are people who are on border states, or someone shows up in a clinic and they actually live in Ohio or they live in Indiana, we're not going to turn people away. At this point, I think the goal is to try to make sure as many people in the high-risk population have access to these things to keep themselves at lower risk as possible. So that's different than the very earliest days of the COVID vaccine. We're not trying to throw up big roadblocks, but we don't want you to advertise come one, come all for your 10 doses. If you have 10 doses, we'd rather be a little bit more targeted than that. So we try to help the people who benefit the most in these early days. Potential spread from sporting events. So this, I'm going to take a stab at this. That's one of those things we just don't know. I mean, so far, this disease has not been one that is just casually spread. It's not one that sitting in a room with someone for an hour and talking to them across a table or shaking someone's hand, unless they have visible lesions. I encourage you to shaking hands. We shouldn't have done before COVID or in monkeypox. It is just probably an unhealthy hygiene behavior, right? But so sanitize often and wash your hands often, regardless of any of these things. But I think it is uncertain with some of these things. If you have, sporting equipment and stuff that people are using, and if they're sharing it and it's coming in extended contact with folks, we are going to learn quickly about just how much fomite transmission is or is not a problem, probably, as we go forward. And I don't think we have strong answers for that yet. Dr. Hodge or Dr. Winter, did you want to fix what I said?
Not fixed, but yeah, it really has not been well defined. I'm going to go try to find the EPA website I was looking at earlier. The whatever we call it, enhanced cleaning procedures that we were all doing for COVID probably is helpful here as well. It may be a little bit more relevant for those things like sports equipment or gyms or things like that. They may need to look at how their processes have maybe become a little bit lax and need to be stepped up again, but there are possibilities.
So on this call, when we asked for certain audiences, so emergency department medical directors, nurse managers in emergency departments, laboratory staff, healthcare acquired infection staff. I see CEOs and all, and that's wonderful too. So thank you for being here to hear the message. But for those other folks closer to the disease management part of this, if you have questions, make sure you reach out to your local health department and or us. We'll do our best to try to be as helpful as we can. Our webpage will continue to evolve and have more information over time, a lot of which will lean heavily on the CDC so that we're as consistent with them as we can be. The phone number we put up there is a Monday through Friday kind of thing, where people can call during typical work hours, Monday through Friday. If they're members of the general public for questions, we still will do our very best to be responsive to healthcare professionals for questions about, specific patients and treatment. But obviously there are bandwidth considerations if the phone is ringing, off the hook. And
Is that the 4907 number?
Is that right?
That was your number, Steve.
Oh, no, you're talking about, no. Tom's being a smart ass. I like that. It's entertaining. No, that's my mobile number. It's not that number, Tom. But I appreciate the humor. But for the people who have my number, obviously, if you think it rises, no one's ever abused my number. If you think it rises to the level, you always can reach out to me. But I appreciate the humor. So there's one other thing I was going to share. I don't think we'll call this group together all the time like this, but if we have any new updates that seem really worthwhile, we may do a shorter 30-minute call and not go over all that background and just say, here's the update, but we wanted to get this started. And we are coordinating with the health departments where we are going to take their time a lot and have like bi-weekly calls with them of differing natures to try to get us all on the same page and make sure that they can be a resource to you because they have access to us. And there's the hotline, the real phone number, Tom, is in the chat there now. And we'll do the best we can here. So, and I don't see any other major new questions here. So let me just ask, Bethany, do you have anything else you want to offer?
No, I do not.
Thank you. Kathleen? No?
Nope.
Thank you. Amy, you good? Wonderful. Anyone else have any questions for the good of the order? I think we addressed most of these things in the chat. And we'll keep working, just so you know, like with, I'm sure not to all of our satisfaction, but we are going to continue to do the best we can. Remember, we do have these small things like massive flooding in Eastern Kentucky, the COVID pandemic still unfolding, the infant formula shortage, which is not yet fully resolved, though it appears to be improving. And oh, by the way, all the regular other work that's being done, and all for the same little public health staff. So we're trying to do the best we can. We always want to aspire to do more. And thank you for your understanding as we work through these things. But we are going to try to work with our local health departments, working with our local healthcare providers, like with Ryan White clinics and STI clinics and FQHCs and all, to try to get access to these treatments in the outpatient settings so that we can have the care provided in settings where people can spend more time and attend to the needs of the patients in a more specific manner, but also avoid swamping emergency departments for all this stuff, which I have a bias, and a vested interest in as an emergency physician. I really don't prefer when emergency departments become the backup source for primary care, but I think all my colleagues know that that's a role we play for society and that we're proud to do it. All righty, folks, thank you very much. We'll get Deb the slide deck. And
Thank you. I actually already have it. That's how efficient your team is. And I have captured all the links that were in the chat. I've got them ready to go. As soon as we get the link to the recording, we'll put that in the update probably tomorrow. I don't think we'll have it today, but tomorrow for anyone who missed it.
Great. Hey, last thing, remember when I said in COVID, one of the things people said when I travel around the state, it meant a lot to them when I said, do the right thing and we have your back. Just please do the right thing. Take care of people, do the best you can, and then we'll all have each other's back because we know that's as good as we can do. So thank you very much. Have a great afternoon, everyone. We'll see you next time.
Thanks so much.
You're welcome. Bye-bye.
Bye.